Yeah, it says you can request the host to allow multiple sharings for this meeting. There must be another presentation that is up, which needs to be cancelled.
It's at the bottom where it says share. And if you click it, it'll say share
Yeah.
screen.
Yeah, that's the problem. I'm clicking it. It's not letting you share.
Okay.
It says you can request the host to allow multiple sharing for this meeting.
Yeah. The middle button, yes, this one. If you put multiple persons, it's the middle option.
Yep, now it's working. Good. We're up and going. Can you see my screen?
We can see the screen now, yes. If you just put it on, yes, slideshow.
All good?
All good.
Brilliant. السلام عليكم ورحمة الله وبركاته. صلاة ليبي برزان وشيستان لشعري سليماني لهولير لدهوغ والأمو كردستان يا عزيز. زور بيخوش حالم كلا ويب الرزم لم لتكيدا وإن شاء الله لتكي تريج نبيو وهموي لخدمتي نخوشي كردستان كذا استرجع قرن بزماني إنجليزي. My talk is a short one and it's mainly focused on an update on the WHO classification of thyroid carcinoma. But I thought it might be very important to cover a few aspects of thyroid FNA regarding sample adequacy and quality. This is mainly relevant to my colleagues from radiology and pathology. They're also their trainees. As you know, it is really important that the sample quality is not compromised because now it is not just a matter of diagnosis, but you may also require the material to be sent for molecular studies, which can have therapeutic and prognostic implications. The thyroid gland is not readily accessible, as you all know. Positioning of the patient in such a way to access the gland during FNA is crucial. Typically, you would lift the shoulder blades and try to hyperextend the neck so that sternocleidomastoid muscles fall back and you can expose the thyroid gland a bit better. The thyroid gland is a highly vascular organ, as was mentioned before. A traumatic blood-stained sample is highly likely if the wrong technique or the wrong needle size are used. Ideally, one would use a size 22 or 25, actually more like 25 or 27 gauge needle. However, if you have a calcified lesion, some authorities suggest using a larger needle, 20 or 22, in which case it might be traumatic and result in significant bleeding. In polycystic lesions, it's really important that the cyst is aspirated, and then one should aim for any remaining solid component in the lesion, because most of the time, what you see in the cyst content is really just thin colloid and a few macrophages. So it's really non-diagnostic. One should aim for any residual solid lesion. This point is really important. The time between aspiration and material transfer from the needle to the slide and the fixation is crucial for optimal preservation. So the quicker, the better. Generally speaking, air-dried smears need to dry very quickly. So the moment you spread it, you need to make it dry and use a hair dryer if you need to. Wet fixed specimens, that is slides, which are put in alcohol, need to be transferred to a fixative promptly after spreading for optimum cell and material preservation. Once there is a bleeding or there is bleeding into a lesion following an FNA, it's unlikely that you will get a subsequent good sample. It's much better to offer the patient an interval fine needle aspiration, which means that you send them home and then you bring them back to try to get a better sample. This basically tells you that your first go is the best go. So it is very important to use the right technique and the right size of the needle and the proper positioning of the patient. Please consider a separate pass in a liquid medium for molecular testing in clinically and radiologically questionable lesions. So if you're not sure it's malignant or benign, then it's a good idea to take another sample and put it in a liquid medium for possible subsequent molecular study. We use the Bethesda system and we recommend using it for the purpose of uniformity. We are currently in the third version of the Bethesda system for reporting thyroid cytopathology, which came out in 2023. This is a simplified and a clear system, and it aligns with the other reporting systems. There are 6 categories, starting from non-diagnostic all the way through to malignant. There is a hard copy of this that can be purchased online, and I think it is really good to have a copy of this book because it contains some valuable information about thyroid malignancy. We have some slides here that show you in chapter 1, for example, there are new data to show that the risk of malignancy, R over M, is quite refined. And based on which category you're going to put the FNA in, then you can have a risk of malignancy. And there's also a usual recommendation that goes with any specific category. There is data to show similar findings for the pediatric age group. You can see a slide here from chapter 14 from the book, which gives a lot of details about molecular and other ancillary tests that can help you decide what to do with the patient in the case of a malignant diagnosis, a TP of uncertain significance, AUS, or if the lesion is benign. So moving to the updates to the WHO classification, which is the 5th edition at the moment. This came out 2022. It includes newly recognized tumor types, subtypes, and a grading system. Molecular cell-derived neoplasms in this short presentation. These are categorized mainly into 3 families, classes. We've got the benign tumors, we've got low-risk neoplasms, and we've got malignant neoplasms. The majority of thyroid tumors are derived from follicular cells, and a small number of tumors arise from the calcitonin-secreting cells, which is known as medullary carcinoma. Rarely, you can see thymic, salivary gland, and germ cell-type tumors in the thyroid gland. The classification of thyroid tumors has evolved beyond the morphologic diagnosis based on morphology as well as molecular pathogenesis. In general, most encapsulated circumscribed thyroid tumors with a predominant follicular growth pattern exhibit a RAS-like mutation or molecular profile. Note that some of these tumors will have a papillary carcinoma cytology. So the FNA on its own, in isolation, does not actually make a diagnosis of malignancy, as it was stressed before at the beginning, that clinical pathological radiological correlation is paramount. Most thyroid tumors with a BRAF mutation or a molecular profile, on the other hand, have a papillary and or an infiltrative growth pattern with the classic atypia of papillary thyroid carcinoma. Both BRAF-like and RAS-like thyroid cancers can gain additional genetic alterations and as a result progress to a high-grade carcinoma. These are some pictures to show you what BRAF-like tumors look like, and it's our classic papillary thyroid carcinoma with complex papillae, showing the classic papillary carcinoma cytology. That is the chromatin clearing, the chromatin margination, the nuclear grooves that you see in some cells, and classically the calcific spherules or the samoma bodies that we see on radiology, typically looking like a snowstorm or the snowstorm appearance. On the right-hand side, you can see a rice-like tumor pattern, which is basically consisting of follicles. There are no nuclear features of papillary carcinoma, and the criteria for diagnosing malignancy are very different, i.e. transcapsular invasion and or vascular invasion. So what are the main changes in the 2022 WHO classification? There are changes in terminology. There is introduction of new entities. There is an adoption of a grading system, which is really important. And then there are other changes specific to different tumor variants is dropped in favor of subtype. So for example, we don't say tall cell or cell variant anymore. We say tall cell subtype. The term variant is really applied to the molecular changes rather than the pathology. The term Hertel cell is also dropped in favor of oncocytic. So we don't say Hertel cell adenoma or carcinoma anymore. We say oncocytic adenoma or carcinoma. We used to count mitotic figures per 10 high power field. Now it's more uniformly done per 2 square millimeter. A new term, thyroid follicular nodular disease, is now introduced to describe benign multinodular hyperplasia or thyroid goiter. New subtypes of NIFTIB and IFTB, which is non-invasive follicular lesions with thyroid carcinoma-like features, have been introduced. Sub-centimeter NIFTIBs, oncocytic NIFTIBs, and for the oncocytic variant, we need at least 75% of the cells to show oncocytic features. Invasive encapsulated follicular variant papillary carcinoma is now separated from other types of PTC because this lesion actually shows RAS type mutation. No papillary microcarcinoma is used anymore. So we used to base it on criteria of less than 10 millimeters. Any tumor less than 10 millimeters was called papillary microcarcinoma. Now we actually have to measure the tumor and we have to mention what specific histologic subtype is the tumor, rather than just call it microcarcinoma. This category is new. Differentiated high-grade thyroid carcinoma is introduced, and it includes papillary thyroid carcinoma, follicular thyroid carcinoma, and oncocytic carcinoma with high-grade features, and we'll talk about this in the next slide. There used to be a category of squamous cell carcinoma and thyroid tumors. Now it is changed to anaplastic thyroid carcinoma STC pattern. As you know, anaplastic carcinoma can show any morphology, and squamous cell carcinoma is now included under that category. even if it looks like a pure squamous cell carcinoma, because these tumors usually share a BRAF mutation with the other tumors of the thyroid that have BRAF molecular profile. So follicular-derived carcinomas, that's the tumors that come from follicular cells, known as high-grade tumors in the new WHO classification, include what you call diffuse high-grade thyroid carcinoma, differentiated high-grade thyroid carcinoma, and the older category, poorly differentiated thyroid carcinoma. So now we have two categories, not just the PDTC. The new subtype, differentiated high-grade thyroid carcinoma, requires the presence of 5 mitoses or more per square millimeter and or tumor necrosis. When a follicular carcinoma has areas of solid or trabecular growth pattern, it is important to examine for mitotic count and necrosis according to the new classification. When the mitotic count is 3 per square millimeter or more in solid or trabecular areas of the FTC, then the tumor should be diagnosed as poorly differentiated thyroid carcinoma. On the other hand, if we have a follicular thyroid carcinoma without solid or trabecular growth patterns, but showing mitotic counts over 5 per square millimeter or equal to 5, then the tumor should be diagnosed as a differentiated high-grade thyroid carcinoma. So it's important to make distinction between these two categories. The grading scheme is also newly applied to the diagnosis of high-grade medullary carcinoma. So the same rules apply to MTC. This paper shows as intermediate grade malignant tumors. But it is interesting to show in this paper that most PDCs, or poorly differentiated carcinomas, had a RAS predominant profile, while the high-grade differentiated carcinomas showed a BRAF predominant pattern. This, to me, suggests that most of high-grade differentiated carcinomas actually come from the sort of papillary type tumors. recurrence. That brings me to the end of this discussion or this talk. Thank you very much, and I'm happy to answer any questions.